All right. Hi, everyone. Thank you so much for joining us for our November Wellness Series. We have Dr. Bose here with us today, and she's going to be talking about deep brain stimulation. So if you have a question, feel free to either put it in the chat or unmute yourself and ask the question kind of as we go along here. If you're not comfortable asking the question out loud, feel free to send it to me in the chat and I can make sure that it gets to Dr. Bose to be answered. So from here, I'm going to go ahead and let her tell you a little bit more about herself and get started.
Hi, this is Dr. Sue Bose, and I'm a movement disorder specialist at Banner University here in Tucson. And Callie asked me to talk to you all about DBS, and thanks for inviting me. And I'm thinking maybe we should do this in a question answer format, or how would you like me to proceed?
Do you think you could start just kind of explaining what deep brain stimulation is for the people who might not be familiar with it?
Sure. So deep brain stimulation is a surgical option for the treatment of Parkinson's disease. So there are medicines, but sometimes medicines are not always effective, and there are certain conditions where then we turn to the surgical option, which is deep brain stimulation. And what the simplest way of explaining it, it's like almost like a pacemaker, except it's for the brain. So it's a wire goes into the brain, and then it's connected to a battery, and then you can send signals into the brain, which then can alter brain function and help with the symptoms of Parkinson's. So the symptom that's best treated with the DBS is actually tremor. And tremor is one of the hardest symptoms to control in Parkinson's disease. So with the deep brain stimulator, we normally have about at least 85 to 90% control of tremors. The next thing which is helped is the stiffness, especially in the periphery, so in your arms, legs, and as is also the slowness of movement. So everything in the periphery is helped with the deep brain stimulation surgery, including the tremor, the stiffness, and the slowness. What it's not very good at treating is the midline symptoms, which include speech or swallowing or constipation or posture or balance. So while it's a good option, we have to very carefully choose people who would benefit from the surgery.
Do you recommend that people do on-off testing before they decide to go through with the surgery?
Absolutely. If it is for Parkinson's disease, we know that if it does not respond to medication, then it typically does not respond very well to DBS unless it's a tremor. So for Parkinson's disease, I always recommend doing an on-off testing. That also gives people an idea of what the medications are doing, and depending on the response of the on-off testing, we can determine what would be an appropriate location, what kind of improvement we should expect, and what kind of medication reduction, if that's the goal we should be expecting.
Elaine, I see you raised your hand. Did you want to unmute yourself and ask a question?
Yes, thank you. Hello, Dr. Bose.
Hi.
Hi. I would like to know, aside from on-off testing, what type of preparation is needed for a DBS procedure?
So if you decide we are going to proceed with the DBS, then basically, other than the on-off testing, I do recommend getting a neuropsychology testing. And then you have to go meet the surgeon who does the testing. And then once once the neuropsychology testing is done, the on-off testing is done, and you've met the surgeon and you feel you would be a good candidate and everybody agrees that you would be a good candidate, then we typically have a conference amongst ourselves to sort of hone in on, what would be the best location, best device. There are 3 companies which make the DBS. So we sort of pick, okay, what would be the most appropriate DBS and what would be the most appropriate location, and then proceed from there.
Thank you.
Any other question?
Yes, Dr. Bose, my name is Joe.
Hi, Joe.
Hi. Your husband did my heart surgery about 6 years ago. Triple bypass. He did a great job. I'm still here.
Okay.
He is the one that recommended that I see somebody because he noticed that my right hand was tremoring. And so I started out with Sarah Sullivan and went to Diane Benedetti, and now I'm with Catherine Bradley as the neurologist that's been handling my case for the last, well, it was February of 2016 when I was diagnosed after I had the testing done. But my tremors have gotten worse, and I'm on a medication. Right now, I just started it called Ritari.
Uh-huh.
And because the regular carbidopa levodopa was wearing off too quick.
Uh-huh.
So this is a time release, and it's been helping me stabilize my on time or off time. So I take it every 4 hours. But I was curious as to what the DBS actually is. Thank you for your explanation. And can you tell me a little bit about what takes place after the surgery from some of the patients?
Sure. So if once we have the DBS done, it's usually an overnight stay in the hospital. And then depending on when the battery is placed, sometimes if we do it on both sides, then the battery is placed about a week or 2 later. So depending on when the battery is placed, we allow you to heal for about, I like 3 weeks, 3 to 4 weeks. And then we have you come back and we do an initial, what we call screening. So in all the DBSs that we have, there are 4 leads or 4 contacts, and we can stimulate you with each individual contact. So we decide, okay, which is the best contact for you, and then do some preliminary programming. And then, depending on how things go, we have you come back and we do subsequent programmings to fine tune things a little bit. So, and then if we find the perfect program, sometimes it takes 4 weeks, sometimes it takes 4 months, sometimes it takes 4 years, but typically it's a very short time where we sort of hone in, and then from then on, we usually just tweak the settings to keep up with your symptoms of Parkinson's.
How do you replace the battery pack? Is that a surgical procedure?
Yes, but it's a really simple surgery, and most of the DBSs that require replacement of the battery, it happens typically every, I would say, 4 to 5 years. There are a few batteries which are the rechargeable ones, which last for about 15 years.
Thank you.
You're welcome.
All right, does anyone else have a question yet? Right. Dr. Bose, do you think you can talk about when you would recommend somebody start kind of thinking about DBS, you know, early on in diagnosis versus later after they've had Parkinson's for a few years?
So there is usually an optimal window where the deep brain stimulator works really well. If you're interested in getting the DBS and you're a candidate, it's probably best to get it as early as possible because we still don't have a cure for Parkinson's. So the earlier you get it, the most benefit is expected from it. If it's a tremor-dominant disease and you're not getting good effect from the medication and or you're having medication side effect and you're walking and swallowing and everything else is okay, then I recommend getting the deep brain stimulation done earlier rather than later. But some people are really afraid of surgery and, you know, and use it as a last option. And that's okay too, but usually there's a window and, you know, if you push it too late, then sometimes the benefits are not as much because, you know, your walking may not improve as much, or your swallowing may not improve as much, or your thinking may not improve as much, or you're sick from something else. So typically, if we have to do DBS surgery, I recommend doing it earlier rather than later.
And then can you touch on any possible maybe negative side effects from the DBS?
So the negative side effect is, of course, it's a surgical option. So we have to make sure that we expect good benefit from the DBS before we would go ahead and implant. There are certain locations of the DBS where it's very effective for tremor control, but sometimes it can affect cognition in a negative way. Sometimes it can affect speech, especially if it's done bilaterally. Sometimes because it's in the brain, it can stimulate areas of the brain other than where we absolutely want it because of the level of stimulation that you need. And so then you have those speech or vision side effects. But other than the fact that, you know, it takes some time for the DBS to work, if you're a good candidate for it, there is no negative side effect. I think the most disappointment that we've had with the DBS surgery is when you have unrealistic expectations from the surgery. So the midline symptoms may not improve. So, and you might not walk too much better, or your fall risk might not go down. And so at that point, you're disappointed because you went through all this surgery and the healing, and then you're not getting the benefit that you expect.
Can you discuss why you would choose to do it bilateral instead of unilateral?
It depends on where your symptoms are. So if you have some tremors on both hands, then you would like the surgery to be done bilaterally. If you have symptoms only on one side, then you want the surgery to be done unilaterally. Sometimes you have really, severe symptoms on one side and maybe mild symptoms on the other side. And then we have to sort of pick and decide, okay, what is it that we are trying to do, and whether we should just do one side and whether that'll be enough, or whether we should do both sides. And so it really depends on what kind of symptoms we have and what it is that we are trying to achieve through the surgery.
Right. Does anyone else have any questions for Dr. Bose about the deep brain stimulation surgery? Do you want to talk about options for battery placement?
Sure. So obviously the wire goes into the brain, and then the battery is, there are actually several different locations where the battery can be placed. So the most common one is right over the chest, and it can be done on either side. The next is it can be done in the abdomen, and it can be done on sort of any part of the abdomen. The only thing with the abdomen is the lead is longer, but really those are the two most common places where the battery is placed. Usually, again, it's up in the chest, but it sometimes doesn't look that good if you're wearing, say, a bathing suit. So then we go for deeper, where it's not as prominent. And sometimes it can be done even lower down, where it's hidden by some other muscles.
Elaine, do you have another question you'd like to ask?
Dr. Bose?
Yes.
What percentage would you say of people who get DBS either can't tolerate it or they decide they don't want it and it has to be removed?
A very small percentage, and it usually has to do, there are 2 or 3 scenarios where we have to remove the DBS. One is if there is an infection, then the DBS has to come out. If the DBS, the location for whatever reason is not perfect, or if it is, your brain has shifted and the stimulation is not at a place where it's helping but causing side effects, then we have to turn it off. The only reason we have really had to remove the DBS rather than just having it turned off is if there is an infection. And then we want it off. But most people, once we decide that what is the goal of the surgery, actually tolerate it fine.
If you had to have a DBS removed because of infection, could you get it again later? I mean, is there a waiting period or?
Yes, we do want to make sure that everything heals. And yes, you can get a DBS later on. But we would have to make sure that the track that we take is different from the one that we chose before. And then the tunneling or the area of the skin underneath which we sort of dig to get to the battery, it has to be completely different and a clean route instead of the one where you had sort of the infection.
Yeah. Okay. Thank you.
Mm-hmm.
Go ahead, Joe.
Doctor, can you kind of give us an idea or give me an idea what the cost of the surgery is and what's necessary? Because I'm on Medicare and I have a supplement, but.
Right. So really the cost, it's variable. All insurance covers this surgery. And I honestly don't know what the total cost is right now. I know that somebody paid out of pocket about 15, 20 years ago. And it cost somewhere between $40,000 and $50,000. But to be honest, I don't know, what the hospital's charges or even what the subsequent charges are for programming. That is something I do not know.
Thank you.
All right. Does anyone else have a question for Dr. Bose at this point? Otherwise, I'm going to go ahead and introduce Eric Rhoden, who does DBS programming. He is a physical therapist. So I'll kind of transition over to him and let him talk about the programming side of DBS more. Dr. Bose, thank you so much for
nice talking to you.
All right. Eric, feel free to introduce yourself and kind of tell us a little bit more about you and what you do in relation to DBS.
Absolutely. Thank you for having me. So as you said, I am Dr. Rhoden, or just Eric, that makes it easy. I have my doctorate in physical therapy. So it's a clinical doctorate versus a medical doctorate. So basically I just can't prescribe drugs, but I know lots about them. I am unique in my role because as a physical therapist, I'm also a deep brain stimulation programmer, which is a bit unique. Currently in practice, I am actually the only one in the US that currently does this. So I practice under the supervision of a neurologist. That's Dr. Eisel's group out of Austin. I work with a nurse practitioner as well as a PA, a physician assistant. And so they essentially are supervising me from afar. So if I come into an issue or I have a medication question I can't handle myself, I will basically ask them for additional support on it. But for the most part, I'm running it under Dr. Eisel's care. So my job primarily is once you've had DBS surgery, so it's been implanted, you are now medically stable, we have your battery in place, or IPG as they call it. Now we have to actually turn it on and use it, right? You went through all this big brain stimulator or surgery. Now we want to optimize its settings. And so my job is to try to get you as optimal as possible. That looks different for very many people. As far as my background, I've been doing the programming side for 5 years. I've been in the movement disorder side for 8 years. Prior just looking at candidacy for DBS. So I've gone through the full spectrum of knowing it as this mystery of DBS, of what is it, how does it work? And when patients would come back to me just on the therapy side, I'm like, why is your balance better? Or, hey, your tremor's better. And they're like, oh, I got programmed. Didn't know what it was. Now I can tell you every nuance of what is going on and be able to program it probably as good as anyone else out there. So that's kind of my background on the DBS programming side. I'm sure we have questions quite a bit on what we do. I can kind of go through a basic rundown of what your first few sessions would be, if that might be helpful. Everybody would be probably good with that?
Yeah, I think that sounds great.
Okay, I got a thumbs up from Joe. I like it. So the day one, you're going to be ideally doing what's called mapping. So they actually try to do some of this interoperatively. So that's, again, unfortunately, I missed the earlier comments on what they do surgically. But when they put those leads in, they actually will rev up voltage while you're in surgery. And then if you're doing the awake surgery, they'll make you go through movements with your hands or speak to make sure we're not getting any side effects. That helps us as clinicians when you get in the clinic where we might be having issues as far as speech deficits or, oh, these areas really did good for tremor control, but if we got too much, we got some pulling, which is called like almost dystonia, or you get these lateral symptoms. We don't want those. So it just gives us an idea of where we start. So day one is mapping, where you come in, we say, hey, let's turn it on. Now, depending on facility, protocols are a little different. Some people you'll come in with your medication on, meaning you've taken your Ritari or your Cinemet or your Mirapex that morning. You come in your on state, and then we try to program you better. Most clinics, though, you come in your off state. You are not feeling very good. You just had brain surgery, you're swelling, you're healing, things hurt, and we told you to stop your medications. So most of the time you don't like us when you come in the door. Then we try to turn on the DBS and make you like us again. So in a standard, I'm gonna do this from the old Medtronic approach, just for simplicity's sake. Each side in the brain, let's say you're doing a bilateral setup, right? So I have leads on both sides. You have 4 contact points on each one of those leads, okay? So think of it like my 4 fingernails on each side. I need to determine out of those 4 contacts, which one or combination thereof works the best for you. So what we do is we go one by one on day 1, possibly even day 2 or 3, depending on what you tolerate. And we say, okay, let's turn up this one and see how good or how bad you are. So let's say you're a tremor dominant patient, your hand's going like crazy. I rev up to, let's say 1 volt, or the new ones, it's milliamps, and all of a sudden your tremor goes away. Well, that's good. I take note of that, and then I bring it back down, and then I go to the next lead. Well, maybe I get full tremor control at 0.5 volts instead of 1 volt. Or when I get up to 1 volt, maybe you start slurring like a drunk sailor. We don't want that. So I take note of that. So we're looking for the pros and cons of each lead. And so what that gives us is what we call our therapeutic window. So when do we start seeing benefit? That's our bottom of it. And then when do we start seeing side effect? That's the top of our window. This is our sweet spot that we get to play in, or we want to play in. We don't want to go above, and what's the point of staying below, because there's no benefit to DBS then. We do that with every single lead on both sides. So as you can see, this takes a little while. Now, some people, when they first come in, they're very sensitive to the voltage, right? When we turn on, we are turning on a new electrical field in your brain, and your brain goes, whoa, what is this? So we usually don't ramp you up to 5 volts and say, okay, we'll see you next week. Your hair might be staying on end on that. We usually incrementally turn it on. And again, every facility is a little different. Some places are very, very conservative. And this is a 3, 4, 5 week process. Other people, it's like, okay, we're going to crank it up each subsequent time you come in. After that, the goal is beat the best program, right? In a nutshell. So let's say I put you on these 2 bottom contacts, right? Going back to our 4 contacts. I turn these bottom ones on, and and you come back in and you're like, Eric, my tremor is fantastic, but I'm really dyskinetic now. So for those who don't know what dyskinesia, right, that's that kind of uncontrolled movement, almost like seeing Michael J. Fox a lot, right? When he does his interviews, he can't stop moving. Well, that's not necessarily a bad thing. That means the current medication regime you have with now your DBS is too much. So it's usually a sign, hey, maybe we can pull back a little bit on your medications. Most of you all like that, right? It doesn't mean we get rid of medication, right? Just to clarify, DBS does not cure. It does not mean that you get rid of all meds. Most of the time, you just get a reduction. On average, 30 to 50%. And that's not indefinite, right? Because unfortunately, this disease does progress. So we're chasing that moving target. So maybe those first couple of years, we get a pretty dramatic reduction, and we're chasing the disease progression, preferably with the DBS. But DBS does have its limitations. We may have to bring medications back on board later on. But ideally, we're going to maximize this thing that we stuck in your brain as much as possible. That's kind of DBS programming in a nutshell, from day one to kind of longitudinal what you'd be looking at. Obviously, I know you guys probably have some more specific questions. I'd love to answer those.
Anyone have
Eric?
a question? Joe, go ahead.
Yeah, sorry, Eric, my name is Joe. Thank you for your presentation. The process from after the surgery, before you get involved, to start to tune things up, how long does that process, I mean, how many days is there between the surgery and when someone would come to see you?
That's an excellent question. So going back to, depends on the facility. It's kind of like a teacher. Every time a student asks, oh, well, it depends. That is kind of the answer here. So our clinic is much more aggressive than your average clinic. We see you within a week of implantation. So you are still healing. You still got wounds. You know, you might have a little bleed back there. We're going to see you and we're going to turn this thing on. Now, other facilities often will wait up to 6 weeks after implantation. Now, why the big discrepancy? Mainly because they're in the mindset of they want to get rid of any post-op brain swelling. We are putting a foreign object in your brain and we're poking through tissue. Well, many times that can trigger a slight amount of irritation or inflammation. In some cases, even a little fluid retention around the lead. It usually gets metabolized and you're fine. But when they look at MRI reports, you can have brain swelling for quite a while after surgery. So a lot of clinics say, you know what, we don't want to get any of that involved with our programming. So let's go ahead and wait, let the brain heal as much as possible, and then let's start getting going. Our physician and our neurosurgeon, at least that we work with, they're like, let's chase the swelling. Let's turn this thing on as fast as we can. They went through the brain surgery, let's do this. And so we chase the swelling. Now, what does the swelling do? It can have an augmenting effect to the program. Meaning, I turn you on and let's say 1 volt worked really, really well for you. But as your brain heals, all of a sudden your tremor starts coming back or you're feeling more rigid. It's not that you're getting worse, it's the brain is now calming down. It's becoming even acclimated to the stimulation. And we're getting back to a baseline level of reactivity to the DBS. So that kind of makes sense. In addition, on a side comment, medication-wise, you can also see an augmentation after surgery of what you used to take. So let's say you're taking 2 capsules of Cinemat 4 times a day. We haven't even turned your DBS on. You've never had dyskinesia before, and all of a sudden you go back to your old regime. It can amplify the effects of your medication temporarily. So some people freak out. They're like, oh my gosh, my medications aren't working anymore. It's not necessarily the case. It's just your brain is in this wired state because, well, they went through brain surgery. And so that neurochemical ratio and kind of homeostasis gets out of whack. And so I will see that often as patients are like, my meds are not working the way they were. So it's just a little tangent on medications.
Thank you.
Mm-hmm.
Eric, how often would you say somebody needs to come back to see you for programming kind of in the long term?
Yeah, so that's a good question. Again, goes back to the depends. So I would say it averages between 3 to 6 months. I know it's a big range, but if you're really, really stable and you're a part of a larger practice, let's say an academic setting where your clinician's also a researcher, they may say, you know what, you're looking really good. Let's see in 6 months and see how things are going. Maybe private practice, they might see you on a bit more of a routine basis, maybe 3 months. Our patients that are stable usually do a 3-month rotation. And we do that for a couple reasons. One, disease does change, but two, we like to keep an eye on the batteries, the efficiency of our settings. And well, we like to be kind of greedy with our programming and seeing if, can we make it better, right? Some clinics, they're like, you know, you're 70, 80% better than you were. Let's just leave it as is. Why fix what's not broken? Fair enough. If I got brain surgery though, I would want as much as humanly possible. And so that's kind of where we go in our approaches. It's like, no, we're going to keep trying to beat our best program. And sometimes that's okay. You're coming in once a week. Other people, like I said, it's once a month initially, every couple weeks, and then it prolongs to, every 6 months. Parkinson's patients, obviously a bit more often. You know, there's DBS for, say, dystonia or for essential tremor. Some of those patients maybe even come in once a year if they're feeling really good and they're dialed in on their settings. But because of the organic and progressive nature of Parkinson's, at the longest, I would say 6 months.
Do you ever see any clients at your clinic that are allowed to do some of the programming themselves, adjusted it all themselves, or no?
Yes, so our clinic usually gives some adjustment always to a varying degree. So again, going back to that, visual of that window, right? That therapeutic window. Maybe this is your window. Maybe I put you right about here. This seems to give you the best bang for your buck with the least amount of voltage. Well, I might give you a 0.5 volt to be able to go up and maybe a whole volt to go down. Because if you're coming into our clinic in your off state, meaning you don't have your medications on board, and man, we got you really, really dialed in. And all of a sudden, an hour later, you take your Cinemet and you're moving around. Ooh, that's too much drug and stimulation. Well, instead of having you ride out that entire cycle of your Cinemet, maybe I just let you drop your DBS down 0.5 volt and see if the dyskinesia goes away. And then you could bring it back up as that med starts wearing down again. So yes, we usually do give some leeway on either end for most of our patients. Now, there are some patients, we give them leeway and they never touch the thing. They lose their remote and they only want us to do it. And that's fine. I have other people, they're the tinkerers. They're walking out the door and they're already messing with their remote. And I'm like, okay, fair enough. And they're like, oh, I went up 2 clicks, and then I went down 4, and then I went up 1. And to each their own, whatever helps you maximize your symptom control, I could care less, as long as it works for you and you're safe about it, okay? Now, that's our clinic. There are many clinicians that I've met, they never let their patients move it. They lock them and they say, this is what it is, come back next time and we'll change it. That's, again, our approach versus other people. Is one right or wrong? No. It's just, okay, we want you to play with it a little bit if you feel comfortable. But if not, that's fine. I'm okay with it. And you also have the ability to change groups, right? So it's not just one group. You can have many groups on your program. So some clinics will do, Okay, let's get your tremor really, really good on one setting. But maybe your speech is a little messed up. Okay, that's your tremor control one. But your walking's not great. Okay, let's maybe make a different group for when you're exercising and you're moving around a lot. Even though your tremor might not be perfect on that setting, your walking looks fantastic. The hope is we can get it all in one. Sometimes not the reality, because we try to get greedy and we want all of it, but then that can trigger a side effect. So on occasion, we do have to split them and say, okay, we're going to bias this group towards these symptoms and this group towards these symptoms.
All right, does anyone else have a question for Dr. Rhoden? Can you maybe talk about how the battery might affect how well it's working? Like if the battery's kind of getting near the end of its life and needs to be replaced?
Absolutely. So depending on the brand, right? So you have Boston Scientific, you have Abbott, you have Medtronic now. So you have 3 different ones. Each of them have their own factory recommended level of replacement. So let's just say, for example, Medtronic's old one. It was 2.68 volts for their life. Most of those start around 3.14 volts. That doesn't sound like much, but that can last up to 5-6 years, depending on the settings. If it's really high and you're using a lot of energy, it may not last even a year. But what happens is once it hits that factory, prescribed level, it can no longer guarantee delivery of a particular voltage. So for example, let's say, Joe, I put you at 2 volts on each side, and you're now down at 2.60 on your battery. It's saying because it goes into kind of life-saving mode, it cannot guarantee that you're actually getting 2.0 volts anymore. Even though your remote says it, even though our programmer says it, it cannot guarantee that anymore. It basically starts alternating itself in this life-saving mode. And so all of a sudden people that let their battery go too low and not replace it, often I'll see their symptoms return. They're like, oh my gosh, Eric, my tremor's gone terrible. My husband can't move anymore. What happened? We grab the remote, we check the battery. Oh, the 2.5, well, no wonder. We replace it, all of a sudden they come back to life. So it's important that you know how to check your battery. And then going back to routinely coming into your clinician, that's the benefit of us seeing us pretty routinely, is we always check that when you're coming in. And ideally, we have a good relationship with the neurosurgeons so we can send you over and get a replacement. Probably another question would be, well, what is the process of replacing the battery, right? So at that point, don't worry, they don't have to go back in here anymore. They don't have to go in here anymore. Basically, whatever scar that they put, whether it be in the chest or the stomach, they basically do a zipper procedure. So they try to cut on that scar line. They pull it out. They literally unplug the old one. They plug in the new one. And they slide it back in the pocket they made and sew it back up. Some people glue it. Some people staple it. Some people stitch it. All depends on the surgeon. Most of those are done in the hospital, but they're usually not under full or general, right? So you're not completely out. Most of them, it's like a twilight state. It's a pretty fast procedure. I think the procedure usually takes like 20 minutes, but you're in there for like an hour for prep and afterwards. So it's pretty low key to get the battery replacement.
Do you also do on-off testing or just the programming?
Yes, so I do. I also do all the UPRS testing as well, on and off. We also do cognitive testing. I do the MOCAs, mini mentals, things like that. So usually, especially pre-DBS, we want to see an on-off state of your medication. So we want to see you in your best state when the meds are really working. And then we want to kind of see you in your absolute worst state. So we clean your system out. Usually most people don't like that. They come in And we want to see on that scale, right? So that scale is out of 199 points, I believe, total. We want to see preferably a 30% difference between your on and your off state on the scores. Actually, it's opposite. Low score is good, high score is bad, okay? So we want to see a big enough difference, because what that usually means is you are a good candidate and you'll likely be very successful with DBS, because DBS should mimic your on-state medications. It doesn't guarantee that it's going to be better than that. It just means it should mimic it and possibly give you less side effects, right? So let's say you're on Ritari and you're having a lot of blood pressure fluctuations or maybe hallucinations. Well, if we can get DBS and maybe pull down that med, maybe not get rid of it, but pull it down, maybe your hallucinations go away. Maybe your blood pressure doesn't jump as much. That would be kind of our goal there. The only caveat to that UPDRS test, if it's not as robust, is tremor dominant patients. So tremor dominant patients that have resistance to the medications, you generally will still do well with DBS. So that's kind of the only little asterisk on the scoring difference there. And that's pretty much it on the UPDRS testing.
Can you kind of talk about how long the on-off testing is and like what someone would expect during it?
Yes. Okay, so the test itself sounds scary, but it's not. Basically, you go through a arsenal and basically questions, and then a few physical tasks that you have to do. A lot of it you've probably already done with your clinician. Hey, walk down the hall, tap your fingers, open your hand, go back and forth on your thigh, stand up, repeat after me. And then we ask you a bunch of questions about your sleep, about your cognition, your hygiene capabilities, your ability to perform daily tasks. And it's a point system. So we're asking, depending on how quick the clinician is or how quick the patient is to respond or explain, you can expect to do that testing taking about 45 minutes, maybe an hour tops, between all the explanations and answering questions and things like that. That's both for the on-state and the off-state. Now, the window between them, so let's say you do off-state or you do your on-state first. How long does it have to be between? Again, depending on the clinic, it's more depending on how long does it take to get out of your system. So certain drugs take longer. So there's some drugs we say, oh, wait, 48 hours before you'll be fine. There's other drugs we say, hey, you have to be off of it for a week. Nobody likes that answer. But it is kind of the reality. These long-acting drugs that have a long half-life, they linger in your system. So even though you're having more symptoms right away, again, we want to see you in your absolute worst. And that's not necessarily a fun process. I mean, there's patients in their on-state, they're walking, they have no disability. And when I have to clean their bill as far as meds, they have to get pushed in a wheelchair. Again, not a fun day. Now they can bring all their meds with them, and as soon as we're done, they can take them, we'll give them a glass of water and they're good to go. And within an hour or two, they're kind of back to themselves. But cleaning out your system that much and then restarting the meds, for some, it may take you 2 or 3 days to kind of get back to yourself, because those therapeutic levels of meds have to slowly rise back up and normalize. So it is a process overall, but the actual testing is usually about 45 minutes to an hour. Joe, you got a question?
I do, Eric. Part of your explanation earlier, I got the impression you were talking about 4 installations in your head rather than 2. Is that typical?
Sorry, no. Still 2 holes, okay? But so this is the lead, right, the pencil. There's 4 points on that lead that I can turn on or off.
Okay.
Okay, that's where the 4 came from.
All right.
And I did it with the old Medtronic one because some of the new leads have also segmented capabilities. So that one contact, let's say these two middle ones on this side, they're split into 33-degree angles. So now that exponentially increases programming capability. Right? So it gets really complicated really, really quickly.
Yeah.
But still, yeah, 2 holes, 2 leads. It's just how many points on that lead can I turn on or off or fractionalize.
Which you can activate more of the brain.
Yep. Or not activate the bad stuff.
Okay.
Steer away from the bad and turn on the good.
Thank you.
Yes.
How often, if ever, do you see somebody kind of perform really well with the on-off testing and the cognitive testing, and then get the surgery, but have not a great response to it?
That's a good question. So it does vary. Often, if they're a good candidate and they're hitting every checkbox, it's pretty rare that they do what I would say poorly. Okay, now I'll make sure I clarify that, right? So everybody's expectation of how they do comes into play here. So, when they're coming in saying, oh my gosh, I'm going to get DBS and I'm turning back the clock. I'm going to go back 5 years. I'm going to feel so much better. I'm going to get off all of my medications. Even though we tell them this, that they're not going to, that doesn't guarantee, and that usually doesn't happen. You still get that excitement and you kind of forget what we tell you. Often those patients, they get out of surgery and they're 6 months, they're a year down the line, and they're like, well, why the heck did I do this? I'm worse than I was. And then we have to talk about perspective. It's like, well, you are on half the medications. Maybe you're still freezing and falling, but you're not having these other side effects. So, what is good for them versus what we see as clinicians, right? So that's one component. Now, there are patients where they're a slam dunk as far as the check marks, and something intraoperatively goes wrong. Maybe they have a stroke, or maybe there's an anomaly in their brain and we can't get the right angle that we want, and we have to offset it slightly. And so we cannot get optimal positioning for their whatever structure we aim for. That does happen. It is, again, less likely because we ideally are doing all the pre-op imaging and the neurosurgeons are good. But sometimes, a stroke, a bleed, they're unpredictable at times. Sometimes they just happen no matter what we do. We've done everything right, and it's just unlucky. Now, there are some patients, they just don't tolerate the DBS well. We put the leads in, everything's perfect. We hit a bullseye, and their brains are hypersensitive to the electricity. Maybe they get weird behavioral issues, which can occur. That can be a possible side effect when I'm turning the DBS on. Or it changes their personality as a whole. Just actually having it implanted, like the brain is reacting to it. That's rare. I think someone had asked a question earlier about how often do the leads, I think it was Elaine, pulling the leads completely out and then putting them back in. Doesn't happen too often. In the time that I've been there, 2 instances that has occurred, and both of them were from what the other doctor was saying, infection reasons. They had an infection. In particular, they were diabetics with poor diabetic management. They got infected because of that. They had to pull them out, heal everything, and then try to put it back in. So those were those 2 instances. But again, going back to the original question, every checkbox and then all of a sudden it's this really poor outcome. It's pretty rare. However, I will say on the cognitive one, right, is maybe they have a underlying or a sleeping cognitive issue that's been, maybe is on the horizon, but it doesn't show up on any testing, right? So maybe they have a pre-genetic disposition to dementia or Alzheimer's or something like that. And we do the surgery, well, that's very traumatic to the body. All of a sudden, boom, we're having these cognitive deficits afterwards. That can happen. One of the other areas is like reactive postural control. So for people that don't know what that is, that's your ability to catch yourself in an unpredictable situation or stimulation. So for example, you're at church and you're talking to someone and a little kid runs by and bumps into you and you have to quickly take a step and catch yourself. That's reactive control. If someone has pre-existing deficits in that and they get implanted, that risk of that getting worse can occur. Doesn't always, but the risk level is much higher compared to someone that doesn't have that problem. So those are areas where I see it's like, man, this person should do well, and all of a sudden stuff doesn't go so well. But usually it's a comorbidity, again, a stroke, a bleed, epileptic activity also we didn't know about that also presents itself, or just a sensitivity to the actual implant. But it is rare.
All right, does anyone else have any questions about DBS or DBS programming? No?
I will say comment if you're okay with that. So for people that are getting it, maybe you all have it, either way, being an advocate for yourself in those programming sessions is also essential, okay? We are human and we make mistakes, right? We assume we know what's best all the time, right? It's a little bit of the God complex when you're a doctor and okay, well, yes, I know best. I've gone to school, therefore this is the right answer and this is the right program. Make sure you speak up for yourself, right? So perfect example, if there's a patient, I've had a patient come in and they're testing, right? The typical testing is, oh, wow, that looks really good. Hey, that looks good. Oh man, back and forth on the legs, fantastic. You're speaking well. Hey, you can walk up and down the hall without instability. Okay, your program's great. I don't need to adjust it. And they're like, well, wait, but what are the specific things that you might be struggling, right? Maybe you love to bake and you cannot get that fine motor control yet to measure out a teaspoon. We'll ask them, like, well, can we try, bring your tablespoons with you and have them try to program your specific needs and desires for you to enjoy life and have a better quality life, right? We had a younger onset person. They wanted to do CrossFit, right? I mean, they wanted to do box jumps still. They walked better than I do, but they couldn't do a box jump. They kept falling when they would do a box jump. Why? Because one leg was not activating when they were doing an explosive move. That one calf was not turning on well. So they literally would go, pew, and they'd shoot off to one side. But on a normal walk, they look totally normal. So for an average clinician programming, you would never really think anything of it. He wanted to do CrossFit, so luckily I have a PT gym in our clinic. So brought out my box and he showed me and I was like, well, that's weird. We programmed specific to his need. So he has his now new workout group that ramps up that side and now he can jump evenly. Okay, so those are those moments where you need to be very specific when you're coming into your clinic and working with your DBS programming. Ask them, like, can we test these specific things? Because this is what I want to be able to do. If you just say like, oh, well, okay, you told me I'm good, so I must be good. That introduces bias. I can bias how you think about your walk just by saying like, oh, yeah, that new program looks good. Your walk is definitely better. And you're like, oh, yeah. It might be. It's called the placebo effect, and I can manipulate your perspective of the situation. And then you go home and you're a hot mess. So again, make sure you get your needs addressed, okay? I see that too often out there where we'll inherit patients from other places, and it's like, why didn't they ever do that? They're like, I don't know. They never told me to hold a cup. And I'm like, well, you love coffee. And they're like, yeah, I can't drink coffee yet. Okay, let's get a cup out, an actual mug. What is it about the mug? Is it the weight? Is it the type of mug that you have? And that's a little adaptation that you can do. So be a good advocate for yourself, okay? Doesn't mean you argue the whole time with your physician. It just means make sure you bring up those specific areas that you want to address.
Eric, I just got a bigger coffee mug so I wouldn't spill it.
There you go, I like it. Or just more coffee, that's always a good thing.
All right, any other questions? And you guys can always feel free to put them in the chat too if you'd like me to ask the question for you. Otherwise, we will tell Dr. Rhoden, thank you so much for joining us. And we can—
My pleasure, thank you for having me. If anybody has later questions, don't hesitate, reach out, send me an email. I'd love to answer them.
Perfect, thank you so much.
Thank you.
All right, well, we'll go ahead and end a few minutes early then, unless anyone wants to jump in last minute here. So thank you again, Dr. Rhoden, for kind of talking about DBS and the programming. We really appreciate your time.
Thank you, Callie, for facilitating this.
No problem, Joe. Happy to. All right. Well, everyone have a good evening, and we'll see you guys next time. Take care.
Thank you. Bye-bye.
Bye.